We would like to acknowledge the traditional custodians of the land that this podcast was recorded on, the Wurundjeri people of the Kulin Nation, and pay our respects to elders past and present. First, a warning. This episode touches on ableism, transphobia, and suicidal thoughts. Listener discretion is advised.
If you ask, is it affordable? The answer is no. And I'm very fortunate and I'm barely affording it.
Having chronic illness or anything like that hinders your ability to have an income so aggressively.
Out-of-pocket costs to see a specialist doctor have really shot up sharply in recent years.
I think the Medicare system is not fit for purpose right now.
Being an unwell woman is expensive, not just because of misdiagnosis and medical gaslighting that delays treatment and drains our income, not just because we're more likely than men to live with chronic illness, or even because we spend a quarter of our lives in poor health. All of that is true, but we also pay more out of pocket for healthcare thanks to medical misogyny that's baked into Medicare and the NDIS. A bigger slice of our spending goes to staying well. And now add the gender pay gap, a cost of living crisis, and soaring specialist fees, and the numbers just don't add up. It's a brutal cycle. Many of us are too sick to work, too broke to rest. And for many, that means skipping care or rationing medication just to get by. I'm Grace Jennings-Edquist. Welcome back to Beyond Hysterical. Today, we'll unpack the hidden costs of medical misogyny, from income loss when you're living with undiagnosed symptoms to out-of-pocket costs like scans that often hit women harder than men. We'll also ask, what's changing? And is there any hope for equitable healthcare in this economy?
They told us, sweetheart, it's all in your head. Just a womb on the move, the man once said. Time moved on, but a shadow remained. Our pain ignored, she's emotional again.
I started as full-time and I was in that job for 3 years, and by the end I was lucky to do 5 hours a week. So that really, really impacted my potential to bring in an income.
Meet Jacinta Dietrich. She's an author and PhD student, and she co-hosts the Differently Brained podcast. Jacinta lives with chronic fatigue syndrome, and she's also ADHD. That means autistic with ADHD. Jacinta knows firsthand how chronic illness and neurodivergence can impact the hip pocket. Jacinta generously agreed to sit down with me and talk money, chronic illness, and how healthcare systems that don't value women equally are leaving us behind. So Jacinta, thank you so much for joining. I wanted to start by asking, to what extent has being neurodivergent and living with chronic fatigue syndrome impacted your income and your ability to work?
So much. The chronic fatigue is really the kicker here, where I didn't realize that I was burning myself out. So I have always been that overachieving, people-pleasing, perfectionist kid all through high school and then through uni and everything. And so that transitioned very easily into workplaces and trying to, be the best and things like that, which turns out will just burn you out if you are neurodivergent and not looking after yourself.
On top of the chronic fatigue, sensory sensitivities related to Jacinta's neurodivergence meant office work wasn't always the best environment for her.
The biggest thing for me was traveling to and from the office. So I could manage a day in the office, but I am not a great driver. I find it very overstimulating and hard. Well, I'm better with public transport, but my sense of direction is terrible. So then I'm constantly on edge. So it meant that by the time I actually got to a workplace, even if that workplace was neurodivergent friendly and things like that, I'm already exhausted by that point kind of thing.
Then there's the way chronic fatigue impacts Jacinta's sleep.
I really, really struggled at the concept that I would have to go back to a traditional workplace because I also have a very strange sleeping pattern because of the chronic fatigue, where there are some weeks where I guess, behave mostly like the general population, except, I probably get up at 10 o'clock and go to sleep still probably at 10 o'clock. I'm only up for 12 hours a day kind of thing. But then there are other days where I wake up at 1 and I go back to sleep at 7 kind of thing. And so that was never going to fit with a traditional 9 to 5.
And like so many others with chronic illness, there are physical limitations to consider.
All of it really kind of doubles down and layers in. But yeah, having chronic illness or anything like that hinders your ability to have an income so aggressively. And then on top of that, there are a bunch of jobs that you potentially can't do. Like even if I could get to an office, I can't do anything that's too physical. So that rules out retail and hospital and a bunch of industries.
Jacinta's experience struggling to hold down a full-time traditional office job isn't unusual for women like her. Many of us end up reducing hours, taking unpaid leave, or choosing flexibility and understanding bosses over chasing higher pay. Sometimes we're forced to leave work entirely, especially when workplace discrimination just makes it unbearable. And all of that leads to one thing: serious income loss. To make things even worse, a lot of women are stuck in this position for longer than they should have to be because their symptoms are being dismissed, misdiagnosed, or just flat out ignored when they're seeking healthcare. It's a self-perpetuating problem. That delay in care means these women get even sicker, their disabilities may get worse, and they may be out of work for even longer, which then makes it harder to get work. So it's not shocking that just over half of women with disability, or 50.7%, are in paid work at all. That's only 1 out of 2. And even then, they're earning much less than people without disabilities. All of this is made even harder because this disability earnings gap is layered on top of the gender pay gap.
So you're hitting the double whammy of, there's so many studies around autistic people and neurodivergent people being underemployed, underpaid and things like that. And then as a woman, obviously the gender pay gap, you just slammed with like, oh, here you go. Instead of like 60 cents on the dollar, you're like, here is your 20 cents. Congratulations. It's hard. It's really hard.
Jacinta's using that 20 cents example for dramatic effect, but she has a fair point. Women with disability are among the poorest groups in Australia. A 2021 audit in Victoria found that over a quarter of women with disability earned less than $65,000 a year. Compare that to just 10% of men without disability who earn in that bracket. And when it comes to top incomes, men without disability were 3 times more likely to earn over $125,000 compared to women with disability. And whatever income we do make, a big chunk goes straight to healthcare. Generally, women spend a far greater portion compared to men of our overall expenditure on healthcare. That's according to research out of the University of Sydney. And chronic illness drives that up even more. Take endometriosis, for example. It costs sufferers an average of $30,900 a year in medical bills and lost productivity, according to one study out of Western Sydney Uni. And that's just one condition. When you're managing multiple health issues at once, this can be incredibly costly and time-consuming.
I probably spent, the past 10 to 15 years trying to get to the bottom of a lot of health stuff.
This is MJ O'Neill. She's a Brisbane-based freelance advisor, problem solver and musician, and she also works for Volcana, a community circus for marginalised genders. MJ is all too familiar with the sky-high costs of healthcare. She has ADHD, severe sleep apnea, complex PTSD, and a dust mite allergy.
So I had to see an allergy clinic. So that.
And all of this adds up to having to see a whole lot of doctors.
Internal medicine specialists. I had to see a psychiatrist for the ADHD stuff and for the gender transition, 2 different psychiatrists. Psychologists, exercise physio, dietitian.
Plus 1 more because MJ is trans.
And then what are they called, the hormone people? Endocrinologist.
And MJ's story? Sadly, it's not rare. Many chronically ill women are juggling multiple conditions at once. Women are not only more likely than men to have a chronic illness, they're also more likely to have several at the same time. Conditions like osteoporosis, arthritis, asthma, kidney disease, you name it, it disproportionately affects women. And for trans women, it's often even more complex than for cis women, with even higher rates of chronic illness in the trans community. Take MJ's sleep apnea, for example.
And all of these things do overlap with the trans experience. Like there's an overrepresentation of kind of allergies, immune system dysfunction in trans audiences, and sleep dysfunction.
Whether you're a trans woman or a cis woman, all these medical appointments chew up a lot of time and energy. For women with ADHD like MJ, there's a cruel irony in the sheer amount of admin required to navigate healthcare systems.
And when you're juggling appointments across 3 or 5 specialists, or even just trying to get referrals, like the ADHD rigmarole of you have to find someone, you have to find the waiting list, you have to get the right amount, you have to get all the paper together, you have to complete the tests, and you have to manage your prescriptions. And like I have a chemist where I'm probably in there like every second day of a week between me and my partner, because it's almost impossible for me to remember when each one runs out. And so I'll get like 3 and then I'll be like, haha, I'm sorted, I've got those. And then like 2 days later, it'll be like, oh, all right, yeah, okay. The metformin's about to run out and you don't have a script. So you have to ring the doctor to get them to do this.
For many chronically ill women, this all feels like a part-time job in itself, which makes fitting in a full-time paid job pretty damn hard.
I think it's paralyzing for so many people. And it's like, we think of it in terms of like neurodivergence and executive function, but everybody has their limits of executive function. There's no sort of infinite amount of organizational ability.
GP visits alone are costly, especially because bulk billing is on the decline. And since women see GPs more often than men, we're hit harder by out-of-pocket fees. We'll get into those GP costs soon, by the way. Then there are specialist costs, which are even more expensive than GP visits. Patients pay a fee for about 2/3 of appointments with a specialist doctor, such as a cardiologist or psychiatrist, and each specialist visit can cost several $100s. Take just one of MJ's conditions, for example, ADHD.
I think I avoided getting an ADHD diagnosis until I absolutely couldn't. And yeah, across everything, at a minimum $2,000, but when you add it all up and how far I had to travel and all the different places, it would be like, yeah, $3,000 to $5,000 easy would be how much it cost.
For Jacinta, the cost of a diagnosis was lower. It's still well over $1,000.
So it would have been about $1,200 for me because I showed up with essentially I'd done all of the quote unquote homework, and I was able to show up with a bunch of the diagnostic tools that they were going to use anyway. It meant that the sessions that I had with the psychiatrist, I didn't need as many as I potentially would.
It's not just psychiatrists charging these high fees either, although research shows they are one of the worst culprits.
I mean, I think these initial consultations with psychiatrists of $700 or more is pretty amazing and hard to justify.
In fact, a new report has found specialist fees in general are so high, they're out of reach for many Australians.
Out-of-pocket costs to see a specialist doctor have really shot up sharply in recent years, so increased by 73% since 2010. And you've got to remember that comes off a high base. They were already higher than GP visits.
This is Peter Breadon. He's Health Program Director at the Grattan Institute. He led a recently published report that found that some specialist doctors are charging 2 or even 3 times the Medicare schedule fee, which is the recommended fee set by the government.
There's a small minority of specialists who are charging fees well beyond the high average fees that you see among their peers. That is less than 4% of doctors, but the fees are very, very high. So for example, to see a first visit with a cardiologist, that's $360.
And these costs are especially prohibitive for patients with multiple conditions, like MJ and Jacinta.
So if you have complex diabetes, you might need to go and see a wide range of different kinds of specialists for managing that diabetes and the complications that can come with it. And then you can easily have co-occurring mental health challenges and need to see a psychiatrist perhaps many times in a year. So these fees can add up to hundreds and even thousands of dollars for some patients who need a wide range of specialist care.
And often, even the poorest Australians have to pay these fees to access healthcare.
These costs often fall on low-income people. So even the poorest people who go and see a specialist doctor, they pay a lot. So 72% of people earning less than $500 a week pay at least one specialist doctor bill a year. And 10% of those people pay nearly an entire week of income in specialist fees. So we can see that, fees are high, they're rising, and they're often falling on the most vulnerable.
The Grattan Institute report found that specialist wait times in Australia are also long, often months beyond what's recommended. And public hospitals do offer free specialist clinics, but these clinics only cover about a third of all care. So patients often face a choice. They wait or they pay. And for some specialists, it's both. But in a cost of living crisis, many patients don't even have a choice.
And we know that about 1 million patients in Australia are missing out on specialist care because of the cost.
Because of high costs and long waits, about 1.9 million Australians delay or skip care each year, leading to misdiagnoses and unnecessary pain.
We've also heard that patients are making really tough trade-offs to afford fees about, can I pay my taxes? Can I pay my heating bill, my food? Can I get my food for myself and my family? So we don't want anyone to be in that situation.
Women are more likely than men to have to make this choice, and some are even dipping into retirement savings to cover medical bills. This dilemma can have life-threatening consequences. When MJ got her ADHD diagnosis about 4 years ago, she was earning enough to cover the thousands in medical bills. And even then, the whole process took about 18 months. But if she had to undergo that process today, MJ said she might not have made it.
I had a very well-paying job at the time. I don't have that well-paying job now. It's like, if I had to brave that process now, I don't know if I would have made it to the end of it in regards to getting help. And then I'm not sure how well I would have gone staying alive after that, to be honest. And it's just because with the resources that I currently have, I don't know if I could afford it. I don't know if I could do it.
Getting desperately needed healthcare shouldn't depend on your income. It also shouldn't depend on your postcode. But currently, many Australians in rural and regional areas struggle to find care, let alone affordable care.
The biggest problem in many parts of rural Australia is just there's too little care to go around. So for the first time, our report added up the private care in a clinic owned by a doctor that's billing Medicare, and then public care, which is the free visits in public hospitals usually, to see the full picture of how much care there is in different communities. And we found that care drops away dramatically once you move out of major cities.
All of this is made all the more troubling because the need for specialist health services is going up, not down.
So with rising rates of chronic disease in Australia, with more and more people who have multiple kinds of chronic disease, this can be a real challenge. The trends are only going in one direction in terms of people needing more care from more kinds of specialists. So we'd expect that over time, more people will be in this bucket of needing that care.
And as we've said, for women in marginalised communities like trans and gender diverse people, the cost and impact of overcoming additional barriers like distance is even greater. Here's MJ again.
Yeah, I live in the centre of the city, and all of these barriers, but it's but I come from the country. I grew up 100 k's away from Brisbane, which is still a relatively privileged position to be in, country-wise. But yeah, I know a lot of trans friends and stuff. There's no choice to stay in the country and kind of try and get healthcare. There simply aren't enough resources across the board in terms of staff, in terms of training, in terms of various kinds of expertise, in terms of funding and infrastructure.
You might be wondering, what about Medicare? Australia's universal health system promises affordable care, but there's a catch. Medical misogyny is baked into Medicare. Women often pay more out of pocket because Medicare's fee schedule currently often sets lower rates for women's health services. Here's a quick primer, just in case you need it. So Medicare sets recommended fees for medical services, but many doctors charge above that rate. And the difference is the out-of-pocket gap that patients are left to cover. Now, this is where medical misogyny shows up. Thanks to discrepancies in Medicare rebates, women in practice often face higher out-of-pocket costs than men, So, for example, women often have to pay more for gender-specific imaging, like ultrasounds. Several peak medical bodies have called out this gender bias, saying Medicare hasn't kept up with the complex care that women actually need. MJ agrees. It's time for a change.
I think the Medicare system is not fit for purpose right now. It's a case of it was built with the idea of, okay, we'll pay for all of this. And then the prices increased and grew. Cost of living increased and grew. But Medicare didn't. And so now you're in this position where, yeah, it's great that Medicare has rebates, but every specialist I go to, I have to pay a gap. And I have really understanding doctors. My psychologist has gone probably about a month without me paying her. Just because I've said I need to pay for other things now. But I've got a 16-year relationship with that psychologist. Most people don't have that.
And Jacinta has this to add.
I'm incredibly grateful that we live in a country with Medicare, but it does not do enough. And I understand, that there's a lot of structures and I understand why there's limitations, but fundamentally, I don't believe it's doing enough for anyone, let alone, underrepresented or marginalized groups.
Medicare's gender bias isn't only about higher out-of-pocket costs for female patients. There's also an issue with how much GPs get paid for consults under the Medicare benefits schedule.
At the moment, the way the Medicare rebates are structured, it essentially prioritizes short episodic care that doesn't necessarily focus on continuity of care or long-term therapeutic relationship with your chosen doctor.
Here's Dr. Iman Joshi. We met her in episode 3. She's a Sydney-based specialist GP focused on women's health, menopausal health, and procedural work involving skin. A bit of background here in case you didn't know this. Australian GPs are paid by Medicare per consultation, and currently Medicare rebates for GP consults are low, especially for issues required to look after women with complex and chronic health issues.
So historically, the Medicare rebate, which is the rebate that the government pays us in order for us to access a doctor or another allied health professional, hasn't kept up with the cost of inflation, cost of living, etc. And so when we are bulk billing somebody, we're essentially saying that the inadequate payment that the government gives towards the cost of your service, we're accepting as full payment. And for the vast majority of doctors, that rebate is so pitifully low, it's less than 50% of the actual cost of providing that service.
As you heard last episode, Medicare prioritises short, single-issue appointments, which makes it tough for GPs to address women's complex and chronic health issues properly. Groups like the Australian Medical Association have called for longer GP appointments to better support patients.
One of the two parties has to suffer if you want the kind of slow medicine that would benefit women by and large. Either the doctor has to take a massive pay cut if we accept the rebate as full payment, or the patient has to have the means to pay for it, which would then disproportionately disadvantage the most vulnerable in our society.
While we're on the topic of Medicare, one thing Medicare does have is something called the GP Chronic Disease Management Plan, also once known as the Enhanced Primary Care Plan. It subsidises up to 5 appointments per year with allied health providers like physios or psychologists. And it's certainly been helpful for MJ.
I've used it to see exercise physiologists. I've used it to see dietitians. I've used it to see speech therapists for gender-affirming speech care, which a lot of people don't know about, because I have a feeling that if they did, it would have been banned a long time ago. But you can get 5 sessions with a trans-focused speech therapist to help with sort of feminizing or masculinizing your voice.
The problem is, when you're chronically ill, a rebate on just 5 sessions a year barely touches the side of the financial pit many of us are in. Here's Jacinta again.
The subsidies need to be better because it was just completely unreachable for me, even with the subsidies that they have. And then equally, those sessions need to be more than 5, because if you've got to split that across 3 different practitioners, you're getting one session with a nutritionist. That's sure, that might be life-changing, but it's potentially also probably not.
Adding insult to injury, so to speak, is that not all chronically ill patients are told this is actually available to them.
It was year 3 of having a chronic fatigue diagnosis that I found out about the allied healthcare plan. I had no idea about that, and it took like 10 GPs in the span of 3 years because my GP just kept turning over at the bulk billing clinic that I go to, because that's the one I can go to tell me that it's even a thing.
Then there are gender issues with the National Disability Insurance Scheme, or the NDIS. While women and girls make up half of Australia's disabled population, they're vastly underrepresented in NDIS support. Why? Because many disabilities that disproportionately affect women, like fibromyalgia, arthritis, and chronic fatigue syndrome, don't fit neatly into the NDIS's current medical model. So to access the NDIS, you've got to be the right type of disabled. Jacinta, for example, has been able to access support for her autism, but not for her other conditions.
My NDIS plan doesn't cover chronic fatigue because it's not considered lifelong, which I understand in theory, but also it potentially is lifelong. We don't know enough about it for anyone to decide that this is not lifelong. So then none of anything like that, like any physios that would potentially help, any nutritionists or dietitians that would potentially help, none of that is covered by my NDIS plan. It's purely mental health kind of stuff.
Men and boys are far more likely to have NDIS funding approved than women or gender diverse applicants. This is partly because NDIS assessments rely on healthcare evidence. And as we know, the pain and symptoms of women and gender diverse people are often dismissed. So while Medicare and NDIS look good on paper, they're failing to adequately support disabled women, one of the poorest groups in the country.
As much as I'm grateful that we live in a country that has access to Medicare and that we do have the NDIS and things like that, they're just not doing enough to be able to support the people that really, really need it.
So just how do we make healthcare more affordable for women and gender diverse people? Here are 8 suggestions on how governments could step in to fix the system. First, Medicare needs to be reformed to reduce women's out-of-pocket costs. Because currently, health services used mainly by women tend to cost patients more. There's some good news in this space. Federal Health Minister Mark Butler has recently launched a gender audit of Medicare's fee schedule. This is all part of a $573 million commitment to women's health reforms by the Albanese Labor government. So the government is finally listening, and that's a solid start. Second, the Medicare benefit schedule needs to be reformed to cover more of the costs for GP appointments. And this will allow GPs to provide unhurried care to women patients, says Dr. Joshi.
We probably need to allow for some way of doctors being able to care for women without worrying about watching the clock at the same time. Because there is just no way that we're going to be able to do comprehensive medical care and access whole person care while we're trying to figure out what the best way to stay viable as a small business or a self-employed person is.
Dr. Pav Naniakara, a gynaecologist from Jean Hales in Melbourne, agrees that GPs need to be better funded.
So I think better funding GPs is a really good idea, giving them time and resources to coordinate complex care. A lot of GPs are under the pump and they're expected to manage everything in 10-minute appointments, which is really not sustainable.
Again, there are some signs of change in this space. The federal government recently introduced longer consultations and higher rebates for specialised gynaecological care, and that kicked in on July the 1st. This applies to conditions like endometriosis, PCOS, and chronic pelvic pain. The government at the same time also added menopause and perimenopause health assessments under Medicare, allowing women to get holistic care from their GP. This is all a step in the right direction. Third, here's another thought. Chronic disease management plans could be expanded so we have more than 5 rebates per year for allied health services, just like Jacinta suggested. Because in a cost of living crisis, 5 appointments can feel like a drop in a bucket, but there's no plans for that change to happen just yet. Fourth, the NDIS urgently needs to address gender bias, starting with better data collection on participants by gender and sex, something it doesn't do right now. A 2023 review of the NDIS did acknowledge that women with disability face barriers to accessing support. But, disappointingly, the final recommendations, so the things government and medical professionals actually listen to, barely touched on gender. One recommendation that did make it in, though, is collecting more detailed data about participants disaggregated by gender and sexuality. Because without being clear on whose NDIS applications are being rejected, fixing the issue will be tough. Jacinta hopes reforming NDIS will go even further.
I think it's, at the moment, what we've got, great, that's an excellent start, but it's not even a baseline. It needs to be so much more, and then needs to account for the fact that we have so much misdiagnosis, and that, there is medical misogyny, and that women and girls are not getting the support that they need unless they find a bunch of specialists on their own and pay out of pocket because nobody understands, because that's not what our health system's based on. It's been based very much on samples of a gentleman.
Fifth, to make specialists more affordable and reduce long waiting lists, the federal government needs to take action to combat extreme specialist fees. Those are the specialists who charge patients about triple the amount of funding that the government actually gives them through Medicare. Peter Breadon and his team at the Grattan Institute want these doctors to face consequences.
So we're saying the government, for those extreme fee charging specialist doctors, the government should withdraw Medicare funding at the end of the year. If they've gone over that level, they should claw back the funding that taxpayers have invested, because we shouldn't be subsidising those really extreme and unreasonable fees.
6, we need more investment in public clinics so everyone can get the care they need. This is Peter Breadon again.
The first step there is for governments to target their investment much better, looking at the full amount of care from public and private that go into a community. And when that goes down too low, investing to expand access.
He says the government could start with this.
They should set a line in the sand. This is the level of care that is a minimum that all Australians should expect to get. And then when care falls below that level, that's where we focus new investment. So that accountability for getting that minimum level of care, we have no system for that now. We don't report the levels of care in different communities. We don't have a target that governments are supposed to meet. And then we certainly don't have investment to get there. So that's the core of it. Work out where the care is needed and put the care there.
At the moment, governments are currently negotiating the next big national hospital funding deal that will last 5 years, starting from mid-2026. And Peter Breadon says this is a real opportunity for change.
And that's the chance to get this planning regime in place, work out where the care is needed, and put that long-term investment in place to get there.
He's also hopeful that public clinics will also drive down extreme fees in the private sector.
And I guess when you look across where a lot of the extreme fees are, where we have less public capacity. So, a big part of building up this public care, particularly in those areas with too little, is about providing that alternative, which both, protects people from the extreme fees they might face in the private system, but also over time it is a competition for those private clinicians, so that, if there's options for patients, then the really extreme and unreasonable fees get harder to charge.
7th, here's another idea. The Grattan Institute says governments can help take pressure off specialist care by helping GPs better manage core care.
When GPs see a patient today who might need advice from a non-specialist GP, one of their colleagues, they typically have to, try and either refer the patient on, which of course exposes that patient to maybe wait times and costs. But if it's something they might be able to manage themselves with a little bit of extra advice from a colleague, it's basically on them to try and track that colleague down, to make a phone call. You've got to schedule time in 2 busy doctors' diaries. Neither of them are directly paid for it. And so it's no surprise that often GPs refer things on where if they got a bit of quick advice, they could manage the patient themselves. This model of what's called a secondary consultation system, that just is a fancy way for saying that the GP can phone a friend. What they do is they can write a message on a secure system, asking a question of a psychiatrist or a cardiologist, and they get a response within 3 days. And then they can decide, do I need to refer that patient on or not?
This system has already worked elsewhere.
And where these systems have been rolled out in Queensland, in Canada, in California, you see that 70 to 90% of the patients that the doctor asks about, they do not then refer that patient on.
The Grattan Institute estimates that this system would avoid around 70,000 visits to specialists if it was rolled out in Australia.
Now, Western Australia has committed to do something like this in the last election. So The next step is really scaling this up and making sure right across Australia we roll out these systems to reduce unnecessary referrals and protect patients from the cost and delays that they cause.
8th, we also need more affordable, multidisciplinary clinics for women's pain and health in these regional areas outside of major cities. You might remember Dr. Pavna Yakara from previous episodes. She works at Jean Hales for Women's Health in Melbourne, which offers this kind of care. And she'd like to see these kind of clinics everywhere.
Within multidisciplinary clinics, like the Gene Health Clinic, we have the opportunity to work with other specialists and allied health practitioners to discuss cases. And I think there are more and more clinics opening up like that take a very multidisciplinary, holistic approach to managing patients. But it's certainly something that could be done a lot better and more widely integrated across, some of the other perhaps smaller or regional hospitals as well.
There is some progress underway in this space. The federal government is rolling out 20 new clinics across Australia, and these will provide expert, multidisciplinary services and care for women with endometriosis and pelvic pain. And in Victoria, the state government's $153 million women's health package includes similar clinics. Here's MP Kat Theophanous. She's the Labor Party member of the Victorian Legislative Assembly, and she's represented the seat of Northcote since 2018.
By the end of next year, 20 new women's health clinics will be open across the state, offering free specialist care close to home. These clinics join our network of 20 sexual and reproductive health hubs, a virtual women's health clinic, a mobile women's health clinic, and an Aboriginal women's health clinic. Together, they'll make up a vastly expanded offering of free, wraparound care for women's health needs.
She says women with pelvic pain, endometriosis or menopause shouldn't have to explain themselves over and over as they bounce between different specialists.
Victoria's women's health clinics aren't just about treating illness, they're about changing the experience. They bring together expert, multidisciplinary teams to deliver free, holistic care that's designed around the real lives of women and girls. Whether you're managing endometriosis, going through menopause, or dealing with pelvic pain or incontinence, you shouldn't have to explain yourself over and over. You shouldn't have to bounce between services or feel like your pain isn't worthy of care. In Victoria's clinics, you'll get care that's connected, compassionate, and expert, with professionals who work collaboratively, understand the complexities of women's health, and know how to respond. And for women in regional Victoria, this is especially critical because the barriers are even higher, longer wait times, fewer specialists, and fewer options.
So some governments are starting to get it.
For too long, women have been navigating a system that just wasn't built for them. A system that dismissed their symptoms, delayed their diagnoses, and made them jump through hoops just to be believed. A system where care has been too expensive, too far away, or just not there at all.
But as with everything in politics, not everyone is on board yet. Kat Theophanous says the political will to advance women's health is growing, but it isn't yet universal.
While we're beginning to see signs of bipartisan support, the truth is that momentum is patchy. Not every state, not every party has embraced the scale of reform that's needed in women's health. And that should give us all pause because we've seen around the world just how easily progress can be undone, how quickly access to women's reproductive health care can be rolled back. We cannot take anything for granted.
This is a good point. While it's great that more women's healthcare services are being built, we need to be vigilant to ensure they're protected.
These services, these reforms, must become permanent parts of our health system, embedded, enduring, and non-negotiable.
Here's hoping that other politicians will be encouraged by the positive response we've seen to the changes that have been made.
The response from the community has been extraordinary. There's a real sense of hope and relief across the community, and an even stronger sense of determination that this is only the beginning, because this isn't just good policy, it's personal. For the first time in generations, women are seeing change that reflects their reality.
Let's loop back to Jacinta, whose chronic fatigue and neurodivergence changed her career trajectory. She's now completing a PhD on a scholarship.
I'm studying a PhD because there was no way that I could see that I could fit into a job that I was qualified to do, whether that was I was going back to retail or hospitality, because I physically couldn't do those. And then I mentally and physically couldn't be in an office, doing editing or any of those kind of things.
So she's found a path that works for her for now. But she's clear that our systems, Medicare and NDIS among them, aren't keeping up with the healthcare needs of women and gender diverse people. And in a cost of living crisis, she says governments need to be treating gender bias like the emergency it is.
They're just not doing enough to be able to support the people that really, really need it, essentially. It's not even keeping people at a stasis. It's kind of like a sad Band-Aid after the fact on just like a gashing wound. It's never going to solve the problem. It's never going to help. Like that wound is not going to heal. It's just going to keep bleeding around the Band-Aid and probably getting bigger and worse. And that's not a solution to me.
I'm Grace Jennings-Edquist. Thanks for joining me on Beyond Hysterical, episode 4. And thanks to my guests, Jacinta Dietrich, MJ O'Neill, Peter Breadon, Kat Theophanous and Pavnani Akara. Next episode, we look at the impact of medical gaslighting and medical misogyny on mental health, and where to find support when it all gets too much. Beyond Hysterical is created and hosted by me, Grace Jennings-Edquist. I'm also the executive producer. Sally Spicer is our senior producer, and Michael Joyner is our audio editor. Don't forget to follow the show on Instagram at Beyond Hysterical. Beyond Hysterical shares the opinions of individuals and provides information for educational purposes only. It should not be relied upon for health or medical advice and is not a substitute for professional health advice.
They told us, sweetheart, it's all in your head. Just a womb on the move, the man once said. Time moved on, but a shadow remained. Our pain ignored, she's emotional again. Brushed off, blamed, in creeps self-doubt.